Okay, so this final part is the Q&A section, and I'd like to welcome to the final segment of the day, Doctors Selim Benbadis, again, Dr. Lorna Myers, Tracee Ridley-Pryor, Michele Price, and Dr. Alex Lehn to answer your questions about functional seizures. Again, for lack of a better term. Please use the Q&A option so that our speakers can also view your questions and direct them to a specific speaker or ask a general question, and we'll let the speakers decide who wants to answer, or let several of them answer. Speakers, if you see a question you'd like to answer, please feel free to jump in. Let's see. I think we already have a few questions that have come through. So, doctors, please feel free to answer whichever ones you want to start, or if you'd like, I can suggest one.
Are you gonna talk the questions, or do you want us to?
Well, if you pick a question out, then I'd ask that you read it out loud, but I'm more than happy to pick one to get everything started. And
is it in the chat or the Q&A?
It's in the Q&A.
Oh, okay.
All right, how about we start with Becca? So I'll read this question for you. And this is to all of the doctors, providers. What is your opinion / thought on NES / FND being related to any type of sensory issues or disorders? If you believe they are related, what's your recommendation for getting help with sensory issues / evaluations, etc., to coexist with our NES / FND treatment?
Good morning from Brisbane, Australia. It's Alex here. Hopefully you guys can hear me okay. Apologies, my voice is a bit off. I promise I've been COVID tested negative yesterday. It's just the old school common cold I think I have. I think it's a fascinating topic, sensory processing issues in FND. For me, I'm convinced it's part of FND. I think the research is good that patients or brains in patients with FND process sensory inputs differently from other people, which I think that itself is fascinating. And we actually have done some research looking into that, and certainly saw, for example, a much higher rate than in a normal population in patients with FND in terms of autism spectrum disorders and related disorders. So there's, for me, no doubt overlap, at least in some patients with that. How to access care might be difficult for you, but certainly it's much easier nowadays and much more accessible to be tested for that, certainly in Australia. I'm not sure how it is in other countries. I think the topic is fascinating. I think it's important to understand it. And I think for patients as well, it's really important to know about this, because I think it really helps you with your understanding. And there's something therapeutic just in that, to have a good grasp on that. And I think it will help you as well in managing your symptoms and your attacks better than beforehand.
Okay, so we have another Rebecca who asks, for providers who are treating folks with PNES, especially those having success, are there any pre or post assessments we can use to document treatment and progress? Any associated studies?
I'll speak first. So I think that all of the studies that we saw earlier today, for example, Gaston Basselet's, the group CBT study, the P study, and so forth, you can really go to those articles and look at the measures that have been used. I'm not familiar with a seizure frequency, intensity measure. And at least from our end, we've always used, just a sort of homemade set of questions. But I think that the best place to go is to previous studies rather than reinvent the wheel and use some of those measures.
I agree with Dr. Myers. We have the same experience. And so we often use the stuff that's been used in the literature already, such as like the Beck scales. I've heard the PHQ-9 mentioned, the quality of life scales, as well as dissociation or other things that you might be interested in looking at.
I keep seeing questions on catatonia, so let me put that to rest. For example, there's one that says, is there a connection between FND and catatonia? Yes, in the sense that catatonia is almost always functional. So if there was a neurologist that labeled that as seizures, then it becomes PNES, if you will. Catatonia 99% of the time is a manifestation of functional disease, yes. Whether it's labeled psychogenic non-epileptic seizures depends if one neurologist decided to make the diagnosis of seizures or not.
We have a question from Lorna. She's interested in knowing about the latest research on medications for FND. She asks about microdosing and CBD, but I would add that because this is an international conference, there are things that are legal or more experimental in some countries and therefore permitted and not in others. So let's keep that in mind.
I'll take the initial part of that. The only medications that we know work for functional disorders, neurological or otherwise, by the way, are antidepressants such as SSRIs and anti-anxiety such as benzodiazepines, because these two things often coexist, depression and anxiety. Other than that, and including CBD products, it's anecdotes. It may or may not work. We don't have enough data. It's being looked at, especially for CBD. There's a ton of trials. But remember, people who sell CBD make all kinds of claims that it cures everything. So I wouldn't believe everything you hear. Trials need to be done. For now, what we know does help, and it's not a cure, as you know, and it should come together with psychotherapy, are anti-anxiety and antidepressants.
For me, this is a question for me personally. Why do those work?
At a minimum, because anxiety and depression are often present. That's a minimalistic explanation. I don't know if the other panel has more to add.
Yeah, I would agree as well. Like I think in our experience, particularly anxiety, high levels of anxiety really often drive functional symptoms hard. In our experience, pure depression, kind of this pure melancholic depression, is actually not that common. In FND, it's often coexistent, but high levels of anxiety, I think, is a very strong driver of FND. And in the other hand, as I think for you as patients, important to know as well, in our experience, those patients with sky-high levels of anxiety, it needs to be addressed. It's very hard to shift symptoms otherwise with other types of therapies, cognitive behavioral therapy or other therapies, unless that's addressed. And while I'm generally not a tablet pusher at all, truly not, in those patients, I do think often medication is needed for the underlying anxiety to manage that. So to answer your question in a short way, I think it's to work or calm down underlying strong drivers of symptoms in those patients.
Okay. Corinne is curious about trials with, let's see, are there any trials anywhere that a child can sign up for? But speaking more broadly, how would you recommend treatment for someone going through this at a very young age?
Find a good child psychiatrist and a good child psychologist, but that's easier said than done for children or adults. As I mentioned before, I get emails every week from everywhere from patients telling me they cannot find the psychiatrist and the psychologist. Either they can't find any or they do, and when they go, they tell them, oh, I don't know about this, I've never heard of this. So it is a biggest challenge is to find competent and interested psychiatrists and psychologists. It's a huge challenge. I don't have a solution for this, unfortunately.
And I'd just like to add, I believe in my experience, because I work in peds. Fortunately, unfortunately, it seems that, can you all hear me okay?
Yes. Very well.
Excellent. It seems that sometimes people are more willing, even if it's not a multidisciplinary clinic, but to come together for children. So I think that if you can find, to Dr. Benbadis' point, a professional that can link you with someone else, although it is hard to find, I think if you don't have that collaborative team already established, you can almost create one.
But by the way, Dr. Myers, among others, has a database, right, Lorna, that we can send. I have your link and I send it to patients to look, and hopefully FND Hope, I was looking earlier, I can add that to the list of information that I give my patients and their family to go and see a database of psychiatrists and psychologists in your area that might be interested in this. Hopefully they are kept up to date, and hopefully there is one at FND Hope. Is there?
They use the same?
I believe that FND Hope maybe is sending or is linking with our non-epileptic seizures.com website. So that page that Dr. Benbadis is talking about is a page where we have been slowly, really slowly, collecting names of psychiatrists, psychologists in the US, and we have a few in Canada and a few in the UK and in Australia. Wait, in Australia, not the UK.
And are you able to keep that up to date?
I mean, keep it up to date. I'm the person who keeps it up to date.
That's amazing.
So someone moves, they tell me, and I change the address or whatever. But the only thing I'll say is that it's disappointing that we don't have all 50 states covered. And obviously there are some states that are huge and we have only one person represented there. You know, I always say, if someone knows or runs into a really good psychiatrist, psychologist, you know, professional of any kind, you know, that has worked well with your FND, with your Pnes, please email me.
So everybody on this conference, if you know somebody, email Lorna. Yeah. She's very good with email, by the way.
So are you. But the other thing, the question about the trials, I am not familiar with any ongoing trials of treatment for peds. But I will say tomorrow at 1, there's going to be a whole peds topic with several speakers. And one of the people there is going to be Dr. Doss. She's a co-author of a book on treating pediatric non-epileptic seizures. It's a great book, you know, so I'm sure she'll mention it there. And if not, you can just look it up, you know, psychogenic non-epileptic seizures, guide children or something like that, Dr. Doss, and it should pop up. It is a book written for professionals. Okay, so this is a book that you would maybe recommend to your child's psychiatrist or psychologist to read. But it is there, and it's actually very helpful. You know, it has resources in the back and all sorts of other things.
And to the research question, I would also recommend clinicaltrials.gov if that hasn't already been mentioned, and type in Pnes. I know there is a study currently going on at UAB, Birmingham, University of Alabama, Birmingham, for pediatrics. And because of Dr. Lorna, I'm in Memphis. I didn't introduce myself, but I'm Dr. Tracee Ridley-Pryor. I'm a nurse practitioner, psychiatric mental health nurse practitioner. But I get emails all the time, of course, from adults, and I treat young adults up to about 21 at the Children's Hospital. But clinicaltrials.gov is also a great resource.
Do you work with Dr. Wheelis?
With the one and only.
He's one of my favorite child neurologists in the whole world.
Awesome. Small world.
And
all right,
guys, can I add as well, for Australia, on fndaustralia.com.au, we keep a database for the Australian community. Slow as well, Lorna, but growing. And I think it's really nice to see. No one wants to be the first one, but it's really nice to see to slowly reach this critical mass of people where people are like, oh my God, all the other guys are doing it as well. So most weeks I get emails of people who want to be added to the database in Australia. So slowly but surely growing here.
to the defense of the mental health professionals, and I keep harping on the fact that it's so hard. Even at our center, we have a big epilepsy center. Every week we make diagnosis of functional seizures, and I don't know where to send them. There are a couple of other obstacles in addition to the fact that I think they're not that interested. The geography. My center is in Tampa, Florida. If they live in Miami or 4 hours away, it's not practical for them to go back and forth. Although that should be fixed by telemedicine, which I would propose for psychotherapy should work perfectly. And the other issue is insurance. Sometimes they don't think, so you have to find somebody that's interested, that's geographically available, and takes your insurance. So there are many challenges to find treatment.
Okay, our next question is from Judy. She's curious, does anyone have any experience with group therapy participants who know each other? And could you provide any insight into that? She follows with her 15-year-old daughter and one of her best friends and a few other people from their dance troupe are dealing with this, believe it or not. They don't really have any local specialists, so they need something, I'm assuming, in a small group setting.
Is that virtual or in person?
Yeah. I don't believe that they have anything right now, but that wasn't exactly explained. Gotcha. I think they're curious about like starting it.
Options.
Yes. More yes, options, but also if that's suggested, should the small group not include people that know each other?
I think it can be tricky, but you also understand that if it's a small, setting where a small town or whatever, I would never encounter this because I'm in New York City. But I think that if that is all that is available, and the clinician feels that they can handle, having more than one person there who actually know each other, in their outside life, that may be the only option. I think that often in rural settings, or in small settings, the rules are a little different, than they would be in the rest of the country. So I don't really have an answer. I'm just saying it would probably be a little tricky, but you also might be able to do it.
Okay.
Oh, sorry. I was just going to add one thing, if that's okay.
Oh, please.
So we had tried to pilot like a small support group, and there were 2 people in the group that had known each other outside of the group. And so the only thing that I would recommend to pay extra attention to is like with the group dynamics and confidentiality, just preserving that within the group dynamics is important to address when they know each other outside of group.
Thank you. I've been told to also remind or invite all of the panelists to update the provider list on fndhope.com whenever you have some time, because that would be a great resource to everyone in the audience today. Let's see. So Jim is curious. Would you mind explaining more about the use of fMRI in association with FND?
My explanation is going to be short. I don't think it helps make the diagnosis. I think it's a costly test. We use fMRI for all kinds of things. I don't think it has a significant role to help, at least certainly not for psychogenic non-epileptic seizures, which, as you heard today, we can easily diagnose with good quality EEG video monitoring.
I agree. Sounds really good, doesn't it? Functional MRI. Surely that's going to be the thing to fix
right.
up
Functional seizures.
For diagnosis. Right. But I think what people need to understand, it's really hard to see what happens in the brain in real time while it happens. And what we're kind of left with at the moment is what's called surrogate markers. So we kind of measure other things while it happens to kind of give us an idea what happens in the brain at the time. And you might have discussed it in the meeting earlier. So functional MRIs, as amazing as they sound, what that measures is changes in blood flow in the brain, depending on how active certain parts of the brain are. And it's actually a really crude test to do. So it's not something that gives you actually detailed looks into the brain functioning for one individual patient. If you have 200 patients in a row and you do those kind of tests, it gives you an idea what parts of the brain are probably abnormally active in either overactive or underactive ways, but not in a way that helps you to make a diagnosis in this individual. I very much agree. Nowadays, we're lucky we can do ambulatory EEGs or video EEGs, which is the test to do to make diagnoses of what I call dissociative attacks, but again, I get a Pnes is the term we use here.
I like dissociative. I like it better than functional.
Thank you. Thank you. We can do a whole meeting about it as well, probably.
And you got rid of the word seizures, so I really like it.
Exactly, yes.
You should have been in our discussion on terminology an hour ago.
Well, it's 5 in the morning for me now. It's too early for me beforehand.
My bad.
And I don't want to skip any questions. And so I'm going to ask this, but doctors, please, and I think I'm going to answer it too, but doctors, please let me know if I'm answering it incorrectly. Angeline asks, is it common or normal to be in and out of consciousness during a Pnes seizure? And I believe Dr. Benbadis or someone earlier said that everyone with a Pnes seizure is going to be conscious. Is that correct? No,
I never say anything with everyone or everything in it. But there is a question like that. There was also a question about how come sometimes I feel something before and sometimes not. Sometimes it lasts 30 seconds, sometimes it lasts 15 minutes. The answer to all of these questions as a group is they are unpredictable. There is no telling. They are different from patient to patient, and even within a patient, they can be variable, which, by the way, is one distinguishing feature versus epileptic seizures, which tend to be stereotyped in a given patient. But there is no rhyme or reason. They are chaotic. Some are short, some might be long, some might have a warning, some might not have a warning. Consciousness may be on and off, just like described. So they're unpredictable. There is no consistent feature. That's part of their challenges.
Okay. Jean wants to know how many people in the world have NES and if there are any mortality stats.
You wrote an article on this, right?
I did, but I don't remember. The article was on the prevalence, and it was mathematically calculated. Like you can probably find it in PubMed. We do know that it was based on calculation of the fact that epilepsy is 1% of the population, 30% are intractable, and 30% of those turn out to have psychogenic seizures when they come to an epilepsy monitoring unit. The question about mortality is a good one. There was a recent paper about that, suggesting that it's a little bit increased compared to the general population. So they should not be taken lightly.
I think there was an article that came out of Australia, right? There was an article, and then there was, I think maybe Marcus Ruber has also written something about that. Yeah, I don't remember the titles or authors, unfortunately. But
yeah, I saw it recently. It's recent.
Yeah.
I can look them up for you guys, but Terry O'Brien was a lead author from Melbourne, Australia, who showed that mortality is increased in Pnes compared to normal population.
Yeah.
Is it possible also that Duncan wrote an article on something about that mortality, or he's in New Zealand, right? For some reason,
right, yeah.
Seems to be happening in Australia and New Zealand, these articles.
Okay.
I'll quickly look it up and I'll put it in the chat if people are interested, the title for the article.
I think that'd be great. So Sonia is curious to know, can someone address treatment for those of us who have been diagnosed with FND from long COVID, i.e. talking about trauma through therapies, push some of us backwards and aggravate symptoms more?
By the way, I'm going to let the psychologist answer that, not me, but I'll just make the comment that oftentimes, and in a case like this, there is clearly an overlap between functional seizures or functional neurologic disorder and PTSD.
I think there is, it's still in the works, the studies on COVID and long haulers and FND, and I actually know some people who are participating in a study, but there are no results yet. In terms of the question about trauma, is it associated to COVID or Raymond? I didn't quite understand that.
Yes, I believe she was speaking about being diagnosed with it or experiencing symptoms through long COVID.
I would think that just having COVID in itself can be highly
stressful.
scary. Yeah, especially, you know, we had no idea what it was, and we're hearing, you know, some very terrible things. And so I think that, you know, and I've had a number of patients who did have COVID, and it has been, can be listed up there as one of those big adversities, right? You know, some people have gotten through it, you know, differently, but some people, you know, it was really something significant in their life, and has had multiple impacts on them. But I really think that we're still in the midst of COVID, and we're probably going to be seeing studies about this and these types of questions some years down the road.
Okay. Angela wants to know, is there anything published on the link between ASD and FND?
Is that Asperger's?
I do not know.
It's, I assume, autism spectrum disorder.
That's what I meant by acronym abuse, by the way. ASD, I didn't know what ASD was.
Yeah, I don't think that there's anything that's been published.
I can tell you a bit from our cluster study we've done last year. We certainly saw a higher rate of diagnosed ASD in the FND group compared to normal population. And in my personal opinion, the undiagnosed rate, because you know nowadays those things get really vague, where do you draw the line where ASD starts? We see features of or spectrum of ASD in a significant proportion of patients with FND. I'm not saying ASD causes FND, but I do think it's a factor that can make the brain more prone towards developing FND, in our opinion.
Yeah, and anecdotally, I mean, I think that, you know, I can say that I have been seeing a fair number of patients with Asperger's or NVLD, nonverbal learning disability, and it makes sense because it is so hard to read certain social cues, and FND or at least Pnes can be interpersonally driven in so many ways, and so I think that explains. Although I'm not saying that, you know, NVLD produces non-epileptic seizures, but it's the ingredients all together that really make a lot of sense that it might do it.
And the way I look at it, and the way I explain to patients as well, what those people often really struggle with is sensory overload. When their brains get overloaded, they really get in trouble. So I think for me, it makes a lot of sense. They can make you prone towards the brain at some point, then responding with, "Oh, this is all too much for me. I switch off."
And I think Dr. LaFrance mentioned it earlier that in many ways it's a disorder of communication. And when we think of ASD, autism spectrum disorder, and again, all the social idiosyncrasies, I would say so. I would agree.
And I see someone wrote in the chat that they found 2 articles on NEA and ASD on PubMed. So they're clearly out there. I just didn't know about them.
So Angeline wants to know, why are Pnes seizures durations unpredictable every time? Sometimes it's 15 minutes to half an hour, but sometimes it can be up to an hour.
I already answered that. Nobody knows. They are unpredictable. They're going to be very variable between patients and even in the same patient. Nobody knows.
Okay. So Amanda says, we're caring for a 16-year-old struggling with FND. She's been diagnosed with non-epileptic seizures, co-occurring with anxiety and depression. The symptoms run the gamut. Are there any programs specifically designed with a cross-disciplinary treatment approach for teens and adolescents in the US?
I'm going to let the PEDS people jump in.
I was just going to say at my center, unfortunately, we don't have a multidisciplinary clinic, but we do work closely together. And I think I enjoy collaborating with other specialties. So I think I hit on it a little bit earlier. I think in PEDS, it's sometimes a little bit easier to collaborate with others. School teachers, guidance counselors. I often ask for release of information in clinics so that I can work with those folks. I don't have a case manager or social worker to help me. But I find that provides great dividends, so I'm not prescribing more than I need to. So even though I don't have a multidisciplinary clinic, I think I work to kind of create that with what I have. So I would encourage to, if you have a great provider that's able to listen to you, don't be discouraged just because there isn't a center with a psychologist or neurologist and everyone else on the team. And the PCP also should be involved, or pediatrician. Would anyone like to add to that?
It's difficult to find treatment.
Mm-hmm.
Yeah,
I
we
think
had
it's a reminder for.
oh, so sorry.
Sorry, Michele, you go.
I was just going to say at Children's Healthcare of Atlanta, they had, before COVID, they had started a program for peds with non-epileptic seizures. But then when COVID hit, they lost a lot of funding and a lot of short staff. And so they had to close that part of the program. And so I know that's something that we've been trying to recreate over in Children's Healthcare as well in Atlanta.
Yeah, and to add to that, I think that's a reminder for all of us. We have the same discussions again and again, like we need, as an FND community, patients with FND, loved ones, health professionals with interest in FND, we need to push the agenda. We need services out there, publicly accessible services across the world. It boggles my mind for something as common as that, how little it's out there. And I think truly when we think, what can we all do to improve things, we need to lobby for better services across the world. And it doesn't take rocket scientists. I think, and it was said beforehand, we don't need the world's best psychologists, psychiatrists, neurologists. No, we need sensible healthcare practitioners, people with common sense and some knowledge about that. A lot of
interest and people,
not rocket science.
And people who are interested.
Yeah. And empathetic.
And empathetic. Yeah. All of the above.
Shouldn't stand out, should it? Should be something that's just everywhere.
Someone asked what multidisciplinary meant, and I just wanted to, okay, someone's covering it in the chat. Sorry for using that term.
There's a sense that you have to come to a center, to a Pnes center, and I don't agree with that, in all cases. I do think that, for example, our Pnes center, we tend to get referrals for cases that are very complex or that have not responded, over years, and prognosis is maybe more questionable. But I don't think that you necessarily have to be seen at a center where they specialize in this disorder. I think it is necessary to find a therapist who is interested, like Dr. Benbadis said, empathetic, and is willing to become educated about the disorder if they're not. It's not a rocket science, to learn how to work with Pnes. And so, if you have a therapist or a psychiatrist who's willing to read, either some of the books that have come out or articles, that's a very good place to start for most people.
And I don't want to discount rehabilitative therapists. So we just talked about ASD, autism spectrum disorder, for a little bit, and we know how crucial occupational therapy can be. And so if there were a clinic with different disciplines for Pnes, I can see rehab services being an integral part of that.
Thank you, Tracee. Deanna's question is, She's had cervical fusion and repaired herniated disc this year, both compressing her spinal cord. Ever since, she's had a range of symptoms matching the list under NFD/PNES. Which is the best way to separate the two diagnoses / healing process, or is it better to assume both are coexisting and treat both?
That is the job of your neurologist to separate what is attributable to the cervical fusion. Some symptoms certainly are, and what is not. So that's for the good neurologist to do.
But I agree, but also important for you, was it Judy, Tracee? I forgot the name, sorry, but also important for you to learn about it, I think. And I think if you can get a good understanding, hopefully with help by your neurologist and your other treating health professionals, to learn by yourself, what are the symptoms I know now are my FND, what are the symptoms I know now are because of organic, structural, cable work damage. It would really help you manage that better in the future. And great example, they often coexist. And yes, this makes things more complicated, but I think even more reason to learn more about it to manage that better in the future.
I also would recommend keeping a log as well of the symptoms that you're experiencing. So like precipitating factors, whatever is occurring before you have the symptoms, trying to see if it's related to a specific trigger or a pattern that you can identify, to see if it's coming from the pain from the neck versus, something from the seizures. So also keeping a log of the symptoms could be helpful as well.
Thanks, Michele. Judy, and this is a return to the question earlier about small group with regard to treatment for her daughter and other members of the dance troupe. She wants to know, is there evidence that one person experiencing an event can set off another person to also experience that said event? That's what's been the experience for her daughter at her school with classmates with the same diagnosis.
Yeah, they use this term, which I will say once and never again, because I hate the term, called mass psychogenic illness, MPI, for people who like the abbreviations. Hate it as a term. I think it's really inappropriate, but it's common. I think spreading of functional symptoms for people who are vulnerable towards them, not that rare at all within families. We certainly often see that, I'm sure all of the other health professionals here as well. But yes, commonly seen.
And Dr. Benbadis, I have a feeling I know how you're gonna answer this question, but I'm gonna ask you anyway.
I have been told I am very predictable with my answers.
Angeline wants to know, why are there symptoms sometimes before Pnes seizures and other times there's no indication of any symptoms before the
yes,
seizures?
You know my answer. There's no rhyme or reason. There's no consistency. It can run the gamut. Some of them are mild, some of them are severe, some are long, some are short. Nobody knows. It's not a simple area of the brain discharging, so it cannot be stereotyped like an epileptic seizure.
Okay. And she follows with, is it normal or common to be unconscious for a long time after a Pnes seizure is over?
It is common, yes. Again, that varies tremendously. Some people wake up immediately. Some people might be out of commission for a longer time. Completely variable.
Can I add something to that as well, to the warning symptoms? Because I think it's fair. I agree, super variable and not that well understood. But what is fascinating, and I'm sure for all of you health professionals see it as well, so commonly we see people initially, when I explain to them, we learn more about the diagnosis, they're like, but for me, no warning signs at all. Like, honestly, I just sit there, boom, the attack hits me. And I completely believe them. They're not lying. I completely believe them. As they learn more about it, though, so often patients come back to me and they're like, oh, kind of funny. I seem to get warning signs more and more beforehand. So I do think a lot of that, though, with that variability has to do with people's ability to read their own body and read their own warning signs. And I think that is something, I guess, what we use for treatment, isn't it? We help people understand and read their bodies better, to read those warning signs better. And to add to that, and I'm sure many of you health professionals and patients see it as well, where person himself or herself is like, no, for me, no warning signs at all. But then you talk to husband, partner, children, parents, or they mention their pets and they're like, oh, it's funny. My husband, he can tell 20 minutes beforehand that I'm going to have one. And I think that's interesting, isn't it? So I do think in the vast majority of patients, often subtle, I admit, but in the vast majority of patients, there are warning signs, and it really helps to be able to recognize those better. Really makes a big difference for therapy. And I'm sure many of you patients see the earlier you can pick your warning signs, the easier it is to manage then the buildup and do something about it.
Thank you, Dr. Lehn. Mar wants to know, are there any trials in Arizona? And I guess to ask a more broad question, is there somewhere where the audience members can find out about trials that are more local to them?
I think we talked about that. One suggestion was clinicaltrials.gov, and I think Lorna maybe had other suggestions, no?
Well, Arizona, there is Dr. Nicole Roberts who spoke earlier, and she mentioned that they were doing certain studies, and she actually runs a lab. You know, I would say contact, and I know we're going to get everyone's email, right? All the presenters are going to provide their contact information, is what I understood. So I'd say contact Dr. Nicole Roberts if you're thinking about Arizona.
Thanks, Dr. Myers. Allison is curious. She's had a Tourette's diagnosis since puberty, but as an adult developed FND symptoms and got that diagnosis. Should she dismiss the Tourette's as FND? She has no family history besides a few realities with transient tic disorder. I'm assuming that's supposed to be relatives.
No, she should not dismiss, but she should speak to her neurologist, who hopefully is a movement disorder specialist, because of course, when things overlap like that, it's very challenging. You heard earlier from Alex, the same thing. When people have psychogenic seizures and epilepsy, it becomes very complicated to separate the two, differentiate what is what. And it's the same with the tic disorder. So these are complicated to manage. And so you need to have a good relationship with your neurologist and try to sort out the two. No, you should not dismiss.
Anastasia's question is, so from what she's gathered from today's sessions, Pnes treatment is patient-driven and includes a variety of therapies which a patient can tailor to their own needs based on what they learn about themselves and their own personal needs. Is that correct?
Yes, with teamwork with the psychiatrist and the psychologist or therapist.
Okay.
And who in an ideal world would be interested and eager and empathetic? Now, in the real world is really not quite like that.
Patient-driven sounds nice, but I think can also sound scary for patients because they're like, great, so I'm all just left on my own again. And I don't want this to sound like that. But what I would say, treatment for FND in general and dissociative attacks or Pnes takes very active participation from patients. I want our patients to be an active member of a treating team. I think that's what it takes. I don't want this to sound like, oh, you're just patient, do your own thing, leave us in peace. You need to fix it up yourself. Hopefully that gets that balance right.
I think also, today we heard many different types of approaches, many different types of treatments. And partially a patient can hear that and say, wow, that sort of fits with me. I can sort of see that rationale, or I can sort of see myself participating in that. But I think also from a clinician's perspective, it's our role to guide a patient in certain directions. So, you might, say to a patient, you've now completed PE, and your seizures are, have decreased significantly. But now I think that it might make sense, to pursue, let's say, a mindfulness-based treatment, or or some other kind of treatment. So, because it sounds a little scary, to hear, it's patient-driven, and almost as if it does fall on the patient's shoulders to decide, figure out, where to get help. But I agree that patient motivation to participate and get better is key. Without it, no amount of treatment and no, particular treatment is going to work. So you need the collaboration between the clinician and the patient. But I would say, you can also rely on the clinician to help decide what would be helpful, or what might be helpful, or what's the next step, and so forth.
Thank you, Dr. Myers. Christine would like to know, is there a correlation between ADD/ADHD and/or autism with FND? As she sees the correlation continuously in the FND community, is there any research?
I think we addressed it beforehand, haven't we? So there's certainly a higher rate of patients with these diagnoses in FND. And we think it's a factor that makes patients at least vulnerable towards developing FND.
And also, as a corollary, these patients are followed on a regular basis by neurologists or psychiatrists or child neurologists, so they are more likely to become diagnosed with functional neurological disorders.
And can someone speak to this happening in clusters, kind of like what's been mentioned with the dance troupe? Is this environmental toxin or a food allergy issue? That's what Lorna is curious to know.
I think that what has been studied in these mass sort of epidemic situations is that often it starts with one person. I believe that some of the findings show that person occupies a position of either popularity or some sort of special role, let's say in the school, and so they are a role model in some way, and then it begins to spread within that group. That's my understanding, but I don't know if anyone else has anything else to say.
And I said, I'm sure you have a lot to read after this conference, but if you want to have a nice book recommendation, Suzanne O'Sullivan, a neurologist from London, Sleeping Beauties is a book she just published last year about this very topic. Awesome book, really, really well written. And she tells a lot of those stories of across the world, clusters and groups of these events, and really kind of tackles different parts of a spectrum. Hopefully I'm not too brave mentioning Havana syndrome. Some of you might have heard this US embassy in Havana, where I would argue very much kind of outbreak of FND there as well. And her ideas around it. So really fascinating read. So for health professionals and as well as patients, Sleeping Beauties.
Thanks, Dr. Lehn. Florence wants to know, is there any research on PNES with senior citizens? I had my PNES event, or she had her first PNES event after a car accident with concussion at the age of 75 years old. I also had PTSD before the accident. Does older age prevent full recovery? I had immersion therapy that helped 60% or helped 50%, for which she's immensely grateful, but I still cannot drive, which is very disturbing and depressing for her. She has been strongly motivated to pursue other areas of treatment.
Typically, psychogenic seizures affect younger adults, adolescent younger adults, but it absolutely can happen in elderly patients, with or without a precipitating factor or pre-existing PTSD. We have a paper on that, in fact. It's not very common, but it absolutely happens. It is treated the same way. And the prognosis is generally more benign simply because it hasn't been going on for as long. So the prognosis, I would say, is generally better than if it's a young adult.
Yeah,
Does
and
anyone
we
else?
also have a paper on that recently that we published and agreed. And the other thing is we saw that risk factors seem to be a bit different. There seemed to be more a tendency to have medical trauma preceding the initial PNES compared to the younger population, where there tended to be more other kinds of trauma, including sexual assault or abuse.
Thank you, Dr. Myers. Mar wants to know, are there any good books that deal with the type of PNES where a person is paralyzed when waking up? Sometimes she can't speak or move her body after waking up. And I think just more broadly, what other books are there for patients to read in addition to what Dr. Lehn said earlier?
I don't think that there's any specific book that goes into something so specific as to what the actual episode looks like. But there's plenty of good books that have been written by professionals, and also a number of good books that have been written by people living with PNES. So I'd say go to non-epilepticseizures.com, and on the homepage there's a rolling window with all the books that we have so far collected that are on PNES. So there are some that are for professionals, some that are for patients.
Also, when you mention episode of waking up unable to move and speak, there is something called sleep paralysis, which is a neurologic condition. And so be careful of self-diagnoses. I showed this morning a cell phone video. Lorna knows that video because it was sent to her simultaneously, of a father sending me a video for PNES, and it was clearly epileptic seizures based on cell phone video. So the diagnosis is not a light one, should not be self-made. It should be made by a specialist in seizures, preferably at an epilepsy center. Because when you say episodes of paralysis upon waking up, to me, it sounds like sleep paralysis.
Thanks, Dr. Benbadis. We're almost done for the day, but I would like to ask one more question. Is there a link between anti-epileptic medication making non-epileptic seizures worse and or more frequent?
No. Anti-epileptic medications, which now are called anti-seizure medications, have a lot of side effects, but that is not one of them. They can cause sedation, blurry vision, sedation, poor coordination, poor balance, etc. They have a ton of side effects, but it should not make any seizure type worse.
All right.
Think about the paradoxical response, where sometimes the patient will have more seizures when they're put on an AED.
Epileptic seizures or functional seizure?
Functional.
If that happens, I would consider it a coincidence. I don't think it's caused by the anti-seizure medication.
All right, that's it for our questions. Unfortunately, we didn't get a chance to get through all of them, but we really appreciate both the panelists and the audience taking their time out of their day to speak with us and to listen and to really create a community here. I hope everyone has learned a lot. This has been so much fun for me. Let's see. If you did have any questions that weren't answered, please direct them to conference@fndhope.org by email, and we'll do our best to get the questions answered, or at least direct you to one of our panelists who can help answer that question. This concludes our first day of the 2021 virtual non-epileptic and functional seizure conference. Thank you for joining us today, and we look forward to seeing you tomorrow. We start again at 9 o'clock Eastern Standard Time. So with that, I hope all of you enjoy the rest of your evenings, except for you, Dr. Lehn. Enjoy the rest of your morning.
Thank you for a great job.
Thanks, guys. Bye-bye.
All right. Take care, everyone.
Thank you, everyone. Bye-bye.
Bye.